Our recommendations are informed by best practices nationwide. For self-directed services, there are promising policies, procedures, and practices that Oklahoma can borrow from Alabama and Colorado. Alabama offers a comprehensive set of supports aimed at helping people with disabilities and their families navigate self-direction. Notably, Alabama offers family empowerment and systems navigation counseling and peer specialist services to help people with disabilities and their families navigate self-direction. Colorado provides people with disabilities and their families with the necessary sources of information to help them self-direct services. The department contracts with a training and operations vendor to provide mandatory consumer-directed attendant support services (CDAS) skills training to participants and/or authorized representatives to provide training to case managers and customer service related to the CDAS delivery option. Importantly, this includes maintaining a call center to provide families with the answers to their questions and providing the training to case managers on how to help people effectively self-direct. Promising states for employment services include Minnesota, Hawaii, DC, Missouri, and Tennessee. Minnesota adopted an employment first policy in 2014 and added employment exploration, development, and support to the state's HCBS waiver services in 2018. Importantly, in 2020, a state task force created a plan to phase out 14C starting in 2025. In 2021 and 22, the state created a grant program and received federal funds to decrease the use of subminimum wage employment for people with disabilities. Hawaii adopted a similar employment first policy in 2016 and has since added employment services to their IDD waiver to support competitive integrated employment. Hawaii invested in discovery and career planning, job development, and individual employment supports. Likewise, in 2012, DC became an employment-first state that prioritizes competitive integrated employment. In DC, both DDS and vocational rehabilitation provide supported employment to assist people in finding and keeping employment in competitive jobs in typical integrated work settings. DDS in DC has established within their waiver services level limitations to provide individualized employment and community day supports. Missouri offers value-based payments to its providers for quarterly reporting of benchmarking data in career planning, job development, benefits planning, pre-vocational, and supported employment. Tennessee offers quality payments for providers who have increased an individual's number of hours worked beyond the average per week in a 6-month period for competitive integrated employment. Providers can receive the incentive payments twice per year. Additionally, Tennessee offers value-based payments to providers who can reduce the number of DSP hours in exchange for the individual using enabling technology to increase independence. Colorado, California, and Wyoming offer promising practices relating to legally responsible individuals or paid family caregivers, which is for parents of a minor child or a spouse. Colorado defines the requirements of who can be a paid family caregiver for a person with disabilities in their Colorado Children's HCBS waiver. The requirements of this include a statement from the child's primary care physician indicating the child's parents and/or legal guardian has sound judgment and the ability to direct their child's care, or the child has an authorized representative who has the judgment and ability to assist in acquiring and using in-home support services, or the child's parent or legal guardian works as an in-home support services agency that is able and willing to support the client as necessary to participate in in-home support services. Ultimately, services are delivered through their in-home support services provider agencies, monitored by case managers, and audited by the Colorado Department of Public Health and Environment. California also defines who can act as a paid family caregiver in their home and community-based alternatives waiver. Adults must meet waiver licensing requirements and provider standards, must provide evidence of being unable to find a local licensed professional, and must be unable to gain or sustain full-time employment due to the participant's needs. Wyoming defines who can act as a legally responsible individual in its comprehensive and supports waiver and sets the maximum personal care services amount to 4 hours per day per participant, which are reviewed monthly by the case manager. Connecticut, DC, Indiana, Maryland, Minnesota, Ohio, and Pennsylvania all offer promising practices and how to effectively manage and promote remote supports. For example, in Connecticut, remote supports are available as a waiver service for people who live in their own home or in a family home and are also available for employment supports. In DC, remote supports are also offered as a waiver service and are available for individuals receiving in-home support or support living periodic services. They can also help support employment. In Indiana, remote supports are available as a waiver service in both DD waivers. In Maryland, remote supports are available as a waiver service and as a service modality. In Minnesota, remote supports are available as a method to deliver waiver services and through the monitoring technology supervision waiver service. Remote supports are also available as a waiver service in Ohio and Pennsylvania. All of these states define how remote supports can be used in their waivers to help support people with disabilities while promoting effective supports. California, Illinois, and Virginia offer promising examples of crisis intervention policies and procedures that can inform Oklahoma's future work. In California, crisis response involves short-term care and behavior intervention to provide caregiver relief and support and protection for participants and others living with the participant. This service can be provided to family members if they would benefit from it. Crisis stabilization includes community crisis homes, CCHs, which are residential facilities that provide 24-hour non-medical care to adults and children with developmental disabilities in need of crisis intervention services. CCHs provide additional assessment, staffing, supervision, specialized training, person-centered planning, and more. The services provided are in the most integrated and least restrictive setting possible and offer supports for up to 18 months. Illinois offers two forms of crisis interventions. The Illinois Crisis Prevention Network, ICPN, which builds provider capacity and provides acute crisis response with 80 clinicians over 6 separate locations, and also offers 24-hour stabilization services. The crisis response team includes their mobile crisis support services team. Crisis stabilization services offer short-term, temporary services outside of existing homes directed at people who are experiencing acute behavioral conditions that result in difficulties in stabilization in the person's existing habilitation setting. They have a total of 8 homes. Virginia's crisis intervention includes the Regional Education Assessment Crisis Services Habilitation, REACH program, which is a crisis response team that includes a 24/7 crisis line, a mobile crisis response team, and can support individuals for 3 to 12 months. Additionally, Virginia offers center-based crisis supports that provide prevention and stabilization services in a residential setting. There are many examples of how states center quality in their DDS services and offerings. We've highlighted examples in Iowa, Arkansas, Indiana, and Virginia that could help Oklahoma. In Iowa, through a contract with their Iowa Medicaid enterprise, the HCBS Quality Assurance and Technical Assistant Unit provides stakeholders with relevant information about HCBS waiver programs. This also includes providing technical assistance, including developing and conducting regularly scheduled webinar trainings, developing and implementing required ISB training, and answering questions from the field about the Consumer Choices Options program. Many states demonstrate quality when it comes to mortality reviews. The most shared metrics in a mortality review include deaths per year, mortality rate, age of death, gender, primary cause of death, classification of death, and type of setting where the death occurred. Arkansas, Indiana, and Virginia all have promising practices relating to their mortality reviews. In Arkansas, the state's Mortality Review Committee reviews all deaths that are unexplained or unexpected and provides transparent data to the public on these outcomes. These practices involve quality metrics, monitoring, and transparency to the public. In Indiana, the state's MRC is presented summaries of all cases prior to meetings, and any member of the MRC can elevate a case for discussion during meetings. Cases where the mortality review treatment team identifies an issue during the review that appear to contribute to the death are always presented for discussion, as are any cases where the MRTT is proposing corrective action. Virginia also facilitates discussion during the MRC meetings for any cases where the cause of death cannot be determined or the death is unexpected. Tier 1 cases include those where the cause of death cannot be determined, it's an unexpected death, abuse or neglect is documented, there's involvement by law enforcement, or there are well-defined risks to safety and well-being.